Okay. Okay, I'll see you in a minute. Hello? Maria, can you hear me?
I can.
Okay. Thank you. Just stay on the line. Don't touch any buttons. That's all good enough.
Net bricks on the healthcare in between. Physics, art, and math got us down this path. Historical tales come alive, where science and stories dive. Blended facts with heart, knowledge from the start. Need bridge blues we sing to the future memory. Health and science in the mix. Midbridge got the fix. Complex subjects made clear. Every episode we cheer. Ramona leads the way, explaining day by day. In the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
MedBits Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming.
Hey, hello, welcome to the MedBix webcast. This is Ramana Annamraju. I'm the host. We are going to talk about a little bit interesting stuff. It's a deviation from the regular other kind of stuff. Actually, it's we have a five. As I come to know that we have a 5,800 outpatient surgical centers in this country. So they provide a more than like a 40 million, close to 30 to 40 million. I'm not sure the number wise, but they serve the people. That's what it's saying. But what are the regulations there? A lot of doctors wanted to open a surgical centers, gastroenterologists, and even plastic surgeons, and all of them. So, what are the regulations required for that? Every state is different. There's a federal rules, there is state laws, and then there's some of them are run by county laws and accreditation organizations. So we have a lots of different people governing these outpatient surgical centers, because that is going to be, if the healthcare to be successful, I think to make it work, we need to decentralize the entire hospital system. We need to get more outpatient surgical centers, no question about that. So not only here, they around the world. So, and also, then we're going to talk about a little bit about the good and bad of the medical tourism. There is a lot of hype towards the international tourism, and we were going to talk about that with Maria Todd. She is joining from Utah, state of Utah. Let me bring her to the table. Maria is a very expert. She has a 30 years experience. She has a PhD. She has 30 to 40 years experience in the around the world. Actually, she was in working in India, Nigeria, Austria, different countries in Europe. So she knows, she's familiar with all the rules and regulations of the surgical centers and medical tourism. Let me bring to the table. Um, Let me bring it to the main stage. Hey, welcome, Maria. Welcome, Maria, to the MedBix webcast.
Thank you.
So tell us a little bit your background, professional background, if you can give me a little bit more.
Well, I've been in the business for 44 years. I have been working in 122 different countries at the behest of embassies and state departments and agencies that are over health ministries, tourist ministries, foreign affairs, international development, etc. I've worked as a facilitator, but that was back in the 1970s. And now I'm the director of business development at the St. George Surgical Center, which is located in St. George, Utah, not Utah. And we are a four operating theater center in one location and a 4 operating theater in a second location about 5 miles from the first one.
Okay, let us talk about a little bit of ambulatory surgical centers. Is it what are the regulations govern those surgical center, outpatient surgical centers? Where to apply if the doctor wants to either a single specialty practice or a multiple? Can they do multiple specialties? A single doctor? What are the regulations governing these ambulatory surgical centers?
Anybody can own one. Corporate entities can own one. Physicians can own one. Groups of physicians can purchase and operate one. Every state in the United States has different rules and regulations. There are 2 primary accrediting bodies, the AAAHC and Quad ASF. AAAHC tends to accredit standard.
What are the abbreviations for those organizations?
The Ambulatory Healthcare Association. You're asking me after on my 14th hour of the day. Everybody talks about them as AAAHC and Quad ASF. We don't use the words typically in conversation. We use the letters.
Okay.
Okay. And when they accredit them, the Quad ASF typically accredits surgery centers that are owned by a physician inside their private clinic. So they're smaller and they have slightly different rules. When you get accredited by the AAAHC, it's usually a freestanding surgery center, and both have pre-COVID launched international arms where they now accredit organizations outside the United States based on the standard of care where the care is being delivered. So a lot of people make the mistake and misassumption that this is an international accreditation to American standards. It is not. It is an accreditation that benchmarks against the average of the care level in the community in which the care is delivered, same as JCI. And so it's voluntary, and the standards are published. It's expensive, and there's a lot of work involved in it, and then you have to do it again every 3 years.
Is there any difference between a single specialty, like a plastic surgeon wanted to to do the plastic surgery, or a GI the gastroenterology doctor wants to open a surgical center? Are there any, if he wants to open to other doctors, can they do multiple specialties? Can they do that, or they are limited to it depends on the regulatory aspect of that process?
It's not a regulatory aspect. It is choice. It is business model and business choice.
So a single practitioner can open up a practice, multiple specialty surgical centers, and then can invite other doctors to do the surgery.
Absolutely.
Can sublease that process there. Okay, let us talk about that a little bit. What is the role of a Medicare in this whole process?
Medicare sets forth the standards of cases that can be performed and paid for in an outpatient setting, and then they reserve some cases like a total hip or total knee revision. Those cases, because of the fact that when you're hammering out the implant, you could fracture the bone. So therefore, they want that case done with the backstop of an of an inpatient setting in case it's needed. Other than that, Medicare pays slightly better and is more receptive to certain outpatient cases. In fact, they want you to explain with real good reason and defenses of medical necessity if you want to do a total knee or a total hip now in an inpatient setting for an admitted patient. If you are doing a standard total knee, total hip, they expect you to do that in the outpatient setting, be it the outpatient setting of a full-fledged hospital or a freestanding ambulatory surgery center.
Is there any reimbursement difference between the outpatient surgical centers or inpatient hospital? Is there any facility fees added, or is there any difference in the reimbursement side?
Yes, and they're all published and available and transparent for anybody to see them.
They have to publish all these prices and upfront?
Yes.
Is it if they don't publish, what they do? Is it something to do with accreditation or some kind of a fine by Medicare?
No, it is a spreadsheet that goes column by column by column. And on the top, on the header line, it tells you, this is what we will pay you if you are a freestanding ambulatory surgery center. This is what we will pay you if you're an inpatient hospital. This is what we will pay you if you're an outpatient hospital setting.
So there are three different versions of this reimbursement you're saying.
Yes, tiers.
So in outpatient center, usually they don't get the facility fee, right? Because inpatient hospital setting, they get the more facility fee. They can add that to the reimbursement structure. Is that right?
Not necessarily.
Okay.
If the case is no longer approved for the inpatient setting, you don't get more, you might actually get less.
So if I understand, what are the procedures, a lot of specialties, orthopedics is, everybody thinks that everybody talks about orthopedics, but they're not the number one. GI is as my study is saying, that 34% of the operations are GI, and then next ophthalmology, and the third one is actually orthopedics. Is that true, or is it different?
It depends on how you're defining the benchmarks. If you're talking about $1,200 cases, yeah, talk about GI all you want. If you're talking about $900 cases, talk about ophthalmology all you want. I don't know if you remember the episode of Lucy and Ethel on the Lucy Show, where they were trying to capture the chocolates on a conveyor belt, and they would move the conveyor belt faster and faster and faster. Well, that's like the comedy. An orthopedic case will bring in $50,000, but takes 90 minutes to do in some cases and 30 minutes to do in another. A cataract surgery will pay about $900 for the lens and maybe another $600 or $700 for the facility. And they move the patients through every 6 minutes. So are you doing a factory model, or are you doing major cases?
So that is a big difference. Is going to make a difference. Let me ask you, the one of the regulations, is it certificate of need is required by the states for these centers? They have to apply?
Only in a few states now. We don't have certificate of need except for places like Maine and Florida and very few others. That whole certificate of need process is going out the window.
It has to be, but there's a lot of, still Georgia is a certificate of need is there in Georgia. They're trying to take it out in Georgia, but they have not done that yet. Let us talk about a little bit about the then hip replacement. You see, what is the average cost of the hip replacement or hip surgery and then knee replacement? What is, just give me a cost in the domestic side, in average cost of that things in the orthopedic side at least.
$30,000 to $50,000, payable at 30 by the insurance companies. We sell a cash pay total knee with robotics and a 30-year implant rated by the FDA for a 30-year service life. We charge $21,300, and we do the same for the hip, and the shoulder is slightly more and non-robotic.
Is it the difference between the robotic surgeries and the regular, the traditional surgery, is any reimbursement difference is there, or the same thing, everything is same?
No, the reimbursement is the same. It's cost neutral because of the fact that the robot is capital expenditure.
Okay. So the reimbursements are same. It doesn't make any difference, right? Yeah.
That's correct.
Yeah. Okay. So actually, I'm the home of, I'm very close to the Intuit Surgical here. Da Vinci robotic company is close by here. But let me ask you another question. Is now you're talking about there is a lot of countries, India, Thailand, all these countries. They are Apollo Hospital. I know very well where I'm from. Actually, originally I'm from there. Apollo. I went to school with the Apollo Hospital. One of the gentlemen there.
I know
So
Sangeeta and I know Pradap very well. So
yeah. No, I know. When he was coming here, he was with me at the time at the Pratap Reddy, and then Sangeeta's husband he worked with me together in New York City. We are friends together from there. And Sangeeta's husband, Mrs. Reddy, and his sister is Shailaja. They're from Atlanta, and she used to work for me at the time. But anyway, so tell us a little bit their model. They're promoting all these the tourism. They were big in tourism they wanted to take American patients. How does it work? I mean, how did they convince, if they who are the people really go for medical tourism?
according to the director of business development, when I was in India in one of the Fortis hospitals, he told me that the US traffic is equivalent to about 0.5% of their revenue.
One
Okay.
very small then.
Very tiny. And I said, well, what about Canada? We've heard about flying busloads of patients from Canada. He said, that's rumor. That's urban legend. Typically, what I have seen in my entire career, reiterated again and again and again and again, is that medical tourism occurs within 2-hour concentric circles in flight duration. And there's several medical reasons and logistical reasons for that.
Yeah. I saw your article on that one. Is I read a little bit about what you wrote. So let us talk about that. First of all, insurance. Who are those people who have a lot of cash that they need to have a cash on their hand to go there? Why they can't do that here? If they have insurance, they more or less they can get the same. If they have insurance, if they have that much rich enough to go that side of the country, what is the benefit of going to India for those people? I want to understand the payer mix in this one. Tell us a little bit about the payer mix.
Well, insurers are not yet paying for medical tourism in any large way. Okay, that's number one. Anybody that tells you that is lying.
Yeah.
Okay, the second thing is, if they have a lot of cash, they have the freedom to go anywhere where they feel the best possible outcome is going to be available to them.
Yeah.
So if they think that that's the Mayo Clinic or Johns Hopkins, that's where they're going to go.
Yeah, correct. So, but what? So they are beating the wrong drums. Why they do that? I was telling them all these years. It doesn't make any sense to me. I ran an IPA. I ran a small mini HMOs. I was working with the HMOs. Why do they want to go and give her that money, or anybody that is not probably legally possible? But how do they give that thing to these people standing there? Already they are the patients of one payer, part of the payers mix here. They're either Medicare or some of the HMOs or a member of HMO, whatever it is. There is no reason to go to the other countries. It doesn't show the incentive. What is a special incentive there, right? To going to the
None
other.
whatsoever. None whatsoever. There are a few sensitivities, and I'll list them for you.
Okay.
One is what we see quite often, what I've seen in Thailand quite frequently, has been physicians from the US that don't want colleagues knowing their business. So they go for the anonymity. The second would be that they go because the procedure that they want, think about IVF right now with all the deliberation about Roe v. Wade. If they want IVF or they want something else in that line, they might leave the country in order to protect their privacy.
They can also go for cosmetic surgeries, right? South Korea is a big in the cosmetic surgeries. People go there quite a bit. Actually, I know a lot of people went there
But,
to get
but who's going to Korea? Who's going to Korea are the Japanese, the Chinese, and other people within those 2-hour concentric flight circles. The critical mass is not from the US. It is not from the Caribbean. It is not from Europe. The critical mass is neighbor countries in Asia.
correct. That's a lot of people told me that in India, most of the tourists come from Africa. Actually, those surrounding countries and to our concentric circle, you say that maybe quite a bit. But let me ask you before that, if I somebody wants a open heart surgery or something, they decided to go and get it done in India. Do they have a statistics about the mortality rate, sepsis rate? Do they provide all those things available to the outside to the people in this country? They don't have, right?
And the patients don't know to ask. That's number one.
Yeah.
Okay. Number two, the patients don't understand NABH or JCI or any other accreditation scheme. They figure if you're open and your doors are open, you're probably accredited. And they're probably right. The third thing is, unless the doctor is some superstar that a rich person wants to see that superstar, those patients are not leaving the United States or their home countries. So there has to be a driver. And unfortunately, in places like India, where most of the doctors are associated with a hospital brand, the hospital brand markets its brand. It does not market the individual doctors. Why? Because if that doctor starts to build a following and develop a brand, they're going to take that and go establish their own thing, and the hospital will be out all of that investment. That also happens here in the United States. The hospital that's directly across the street from my office employs many physicians across many specialties, but they do not market them individually because they don't want them to establish a premier brand. They want the hospital to be the brand.
But yeah, before I ask that question, what that is not a right system. You're artificially increasing the keeping the prices up. The decentralizing is that you have multiple surgical centers open up and decentralize the healthcare system. That is a way to reduce the cost, not by artificially keeping up a silo centers and then
Exactly.
send them to the one places. It doesn't make any sense to me in that sense.
Well, there's an old saying that an attorney told me one time. He said, if it makes sense in business, it's probably illegal in healthcare.
Yeah, yeah, that's really maybe true. Let me ask you that this is the medical tourism, another medical kind of tourism. There's a lot of people go on cruise ships. That kind of a business could be a good model, right? The people are a lot of executives travel other countries to monitor their health care and doing that kind of a system. Is it what the business? What the
It's
business?
been tried in the 30 years that I've been in medical tourism. It's been tried over and over and over again. It does not work. Number one, because the stabilizers on the ship make it too difficult to operate in the surgery. Things move. The Mayo stand items move. The back table items move. Who's going to be grabbing the patient and breaking sterile field to grab onto something when the ship starts to rock back and forth? That's number one. Number two, because of the flagship registry of the ship, if the patient has a complication, under which law will the case be tried? It's in maritime law.
Yeah, that is a bigger problem. So what about
Then you have on top of that the medical records requirements. A medical record is structured according to a national or state or both configuration and template. So if you are in international waters, which medical records format applies? Which standard of care applies?
Yeah, the huge liability issue. What about the transplantation? A lot of times that people want to get a liver transplant or kidney transplant in other countries. That's where the medical tourism has some kind of a options available, because a lot of restrictive, certain countries are very restricted, right? There's the United States, you have to go through an organization. It's a very restrictive. You cannot be, because you cannot buy them through money. So are there any things that area can go a little bit progressive in that area? Medical tourism can be attractive to other people now.
Well, okay, so in Thailand, I worked with the liver transplant program. And one of the things that we learned was you cannot procure the organ from another source. So you have to bring the organ and the donor with you.
Mhm.
So unlike the UNOS system that we have here in the States, if you want to have a liver transplant in Thailand, you must bring your donor with you. That means 2 airfares, 2 risks for DVT, 2 risks for other altitude physiology problems, 2 hotel stays, and 2 sets of medications and everything else that goes with the liver transplant complex.
No, Maria, nobody's going to take it from United States to a patient to
They
Thailand.
do.
They,
They
doesn't make
do.
any sense. I don't know. It make the so unless that system is restricting them. But most of the times in Pakistan and other countries, they sell these third party, some kind of a illegal way. They sell these organs. There's a middleman. They sell these organs. They do that. That's why they go there to get the transplantation in other countries. Even sometimes it's a very gray law. There's not a clear distinction there. In India, there's a 1.5 billion people there. They want to get the organ from there. It doesn't make any sense a whole lot. I mean, unless it's says that you can do it here, that's a different issue. But most of the time, the opportunity is they want to get the organ from the local people. That is the reason that may
Then
be.
in the Muslim countries, they also have to make sure that the donor was Muslim.
Yeah. Oh, really?
So,
I didn't know that.
yes,
Yeah. Okay.
yes, the organ has to be halal too, not just the.
Okay. It's interesting. Yeah. Okay. I'm not a Muslim, but I don't know all those rules. But I came from Hyderabad. Hyderabad is a 50% of the Muslims there. I don't know much about it, but so if the recipient is not a Muslim, they cannot get if the recipient is not a Muslim, they cannot get the Muslim donor.
No, vice versa. If
Right.
the recipient is looking for a donor, then the donor must be also Muslim.
Hmm. Okay, so this is a very strange kind of rule, but I don't think India has that rule. But let me ask you a question. Now let us move on to the surgical centers. We know that surgical centers now. Why the doctor? We tried. One of the physician friends of mine here tried to open a hospital, and then did not work out. There's the Obama administration or some other administrations came out, and they were against the doctors owning the hospitals. Tell us a little bit. Is there anything going on in that direction? Is that doctors can own hospitals now, or it still is a big challenge?
Years ago, there was an attempt to quash development of ambulatory surgery centers. Sorry, I have hiccups. And they removed that after a while because it was bad for competition. It inhibited the competition. But for a while, there were many, many, many new licenses of physician-owned surgery centers. And they had a little discrepancy that they had to sort out about kickbacks. If you own the surgery center and you refer to that same surgery center that you own, was that a kickback? And did it violate the anti-kickback statute or the Stark bill? They've since sorted all that out, and that's not a big issue as it was 15, 20 years ago.
Let us hold on that one. So you're saying that to me, if somebody wants a doctor wants a multi-specialty clinic, and then he brings the other doctor, gets GI doctor, and do the surgeries there. He can bill and he can sublease the space. He cannot. Can they open it together? All the doctors together open a corporation and bill together.
Yes.
It is not a violation. So it's not a stock law violation there. Even supposing use.
Nope. Because the surgery center is going to bill for the capital expenditure and the facility and the staff. The surgeon is going to bill for the surgery. Anesthesia is going to bill for anesthesia. And the owner of the facility, if it is 1 doctor, 10 doctors, 50 doctors, they are going to bill for the implants, the hardware, the drugs, etc. All the consumables.
How long it takes to get all these accreditations and Medicare approval and all those things? In general, it's a single specialty practice, GI practice wants to open a endoscopy center, endoscopy surgical thing. How
It
long
matters. There is no difference. The paperwork is the same, whether it's a single specialty or multi-specialty. And it takes about 3 years from architectural plans to commissioning, opening the doors.
That's a long time. So even if we want to open a small one in the next to his office, right next to his office, one room surgical center, it does a single specialty. Is still that is the same amount of time?
It can be. It depends on how quick they are with the paperwork. It also depends on how much the market wants to contract with them.
Okay. Now let us talk about the payer mix. I saw very interesting. I was talking about that actually in one of my episodes before about the benefit managers. I went to city. I used to live in city of Atlanta, and then I went to the benefit manager and was trying to convince her the commissioner of the benefits by putting the not surgical center, but at least a primary care center in their offices in the city hall. It can drastically reduce these things. They didn't understand it at the time. So I saw your attempt also you're pitching to the benefit managers. Tell us a little bit about that. That's really payers have. This is the problem is not a benefit managers, their bosses, their mayors, their CEOs really need to step in because they don't understand it. That's one of the things. Tell us a little bit about the benefit managers and the payers. How can they reduce the cost of their employees' healthcare costs?
Well, it's a complicated system, and employers that have greater than 300 employees and dependents typically decide to be self-funded under ERISA regulations, not insured. They lease the network of a bigger insurer, but they self-fund the claims. So now, if I have an employee work site, one work site with 700 employees working in 3 shifts, plus their family member dependents, it makes sense for me to set up a primary care clinic,
Yes.
own it, operate it, insure it, and hire the practitioners.
Yeah, agreed. No more. Yeah, absolutely.
But
Now,
many employers are not educated enough, and the brokers are not educated enough to explain the beneficence of some project like this.
that is a bigger challenge, absolutely, because now there are a lot of direct specialty care, direct primary care sort of popping up everywhere. Now they're trying to come back to concierge medicine. That's probably that organizations, they need to, even the doctors don't understand what the benefit managers do. That is another challenge itself. They don't know how to go to the city hall and ask for it and then say you can reduce the cost of this whole thing. they can drastically reduce the cost, right? You're saying sometimes 30 to 80% of the cost can be reduced in the. I saw in your. Is that right? That you can reduce
Yeah.
that much cost?
For example, if a mother takes a child to the emergency room, you can expect that the bill generated is going to be in the vicinity of $1,600 to $2,500 for that ER visit.
Yeah.
If they were to be able to go to the local worksite clinic
Yeah.
operating 24/7, 365, they could probably achieve the same identical outcome for less than $600.
Yeah. No question. This is one thing. The politicians are not educated enough. I think that's they need to be really need education. Mayors need once they catch that they can save money, they will do it. But they don't know. Nobody is educating them, and they don't understand healthcare. That they get nervous about it. So I give it to HMO, and then I give sublease the whole network to the somebody. That is a bigger challenge, no question. But in one area, I think I was suggesting to the a lot of these direct primary care and direct specialty care doctors, go to the small cities, small towns, go and convince the managers, hey, you can do they have small town means they have a minimum 300 employees. This usually employees is usually 1,000 people. They, that is one thing. Let me ask you a question. How many cities and governments have a risk retention groups, which is self-insured groups? Coca-Cola has a self-insured group. Most of the big companies have self-insured, right? They're self-insured networks, right?
There's a little discrepancy there. You have to be more accurate in the choice of the words. They are not self-insured, they are self-funded. If you follow self-funding, they are using either a trust fund, a 501c9 trust fund, or the assets of the corporation under the ERISA law, which is Section 29 of the U.S. Code, and it is governed by the IRS and the Department of Labor. If you say self-insured, you are talking about state insurance regulations, and that is not self-funded. The majority of the Fortune 1000 companies are self-funded,
Oh,
not self-insured. The majority of the cities and municipalities and those other public organizations are self-insured.
so tell me again the difference between the self-insured and self-funded. They are governed by state. Self-insured is governed by the state, or self-funded is governed by the state.
Self-insured is governed by the state. Self-funded is governed by the Section 29 of the U.S. Code and
Okay.
the Department of Labor and the IRS. So if I have a denied claim and I wish to appeal and say that the employer did not respect the needs of the patient, I don't appeal to the Department of Insurance. If they are self-funded, I actually send my appeal to the Internal Revenue Service. Why?
Mm-hmm.
Because
Interesting.
they are taking the expense for the care above the line. And if they are able to get that deduction, then the IRS regulates that expenditure.
But some of these, you call it self-funded, maybe they do reinsurance by Lloyd's of London. We did that for one of the things. We can do the reinsurance for that, right? Some people go there and get the reinsurance. All the other
But that's specific to excess loss.
you're correct. Yeah. So what about the retention groups? Bunch of doctors get together, risk retention. Can you tell us a little bit about the risk retention groups?
Well, a lot of risk retention groups actually come together as an IPA or an MSO
Yes.
or a PHO even, and they purchase offshore or other captive insurance. So they are not only minding the store as far as utilization and quality, they are also owning the captive, so they own the premiums. If they don't spend it, they get some of it back if that's what's written into the bylaws.
Now let us talk about a little bit about the concierge medicine. What is the trend in this country right now about the concierge medicine? A lot of people are getting tired of corporate medicine and they're trying to move into the primary care, particularly direct primary care. They're trying to be concierge medicine. How successful the concierge medicine is still is in the infancy stage, or is it how do they market? Where they market their is it health savings plans are good targets for them? Tell us a little bit about that concierge plan. Concierge.
Concierge medicine is ideal for the person who is tired of the 3-minute McDonald's drive-through visit from McClinic. Okay. They don't want to have primary care like a factory anymore. They want the doctor to have time to listen to them and answer their questions. And so what we have right now is a problem that is actually increasing due to concierge medicine. And here's how I explain that. When you have a concierge medical practice and you market it and you say, I'm going to charge you $2,000, $5,000 for the year, plus I'm going to bill you for each visit. The people who have it say, I want that. The people who don't have it are dumped to the curb. That's number one. Number two, the Medicare regulations do not allow you to sell under a membership plan that which Medicare already pays for as a Medicare benefit. So that means all of the seniors are jettisoned out of that doctor's previously existing practice. So what happens at that point is now we have a doctor saying, instead of 10,000 patients, I am going to take 300. The rest find their own way. The problem is we have no landing spot for the people who were disenfranchised.
Can you do
So
both? Is it possible you can do both? You can have 300 the private patients and then Medicare patients separately. You cannot do that.
Not anymore. As of April 1st, 2018, Cigna, Aetna, United, and others, Humana, they all put in, not in the contract, they put in the provider manual where nobody saw it, the prohibition against selling a concierge package and requiring concierge membership in order to be seen by a participating physician in that network, because they considered the payer considered the patient chattel and their corporate asset. And so they said, we brought them to you. We put you on the list of available providers. You cannot now charge them a $2,000 fee or any amount, 600, 300, does not matter. You may not operate a concierge practice and charge a membership fee to the patients who have Cigna, Aetna, United, et cetera. And that happened April 1st of 2018.
Hmm.
So
Uh,
there
that
were
is
doctors
okay.
who were running a hybrid, but
That
not
is
anymore.
such a invasion of privacy in my view. Is unfair, because to the patient, I want to keep my insurance, but that I want to have a special access to the doctors. That is not possible. You're saying so they're restricting the kind of rationing health in that sense.
What the corporate payers are doing is saying, this is my corporate asset.
Yeah. Yeah, well, that's very hidden fact, right? They just human beings are their corporate asset. Yeah, that once they know about it, then let them vote for that kind of a voting elections has to decide on that one. Are you an asset for the corporation, or you a independent thinker, and you need a special. It's really. What about let us talk about that, practical thing, health savings account. How can they tap, these doctors can tap health savings accounts? The primary care doctors, concierge medicine doctors.
They would have to sell a product that is permitted to be paid for by the HSA or the HRA under IRC 213D, which is publication 509 of the IRS. If the service is not listed in includable services under IRC 213D, you can have an HSA, but you can't use it to pay for the services that are not includable. And it's publication 502, I misspoke.
So you're saying that IRS is telling what procedures to be allowed?
Yes.
So if I want a psychologist to go, and then I want an additional, back pain injections, so you have to go to the IRS for that?
No, you have to pick the services. If you want to use your HSA money, you must use it on services that are in publication 502, which is the substance of IRC 213D.
They have the list of procedures. They have IRS has a list of procedures what you can offer or not by employees.
Yes,
IRS is coming up with a list. That's what you're saying. Is that
it's been around since 2003.
so? It doesn't make any well. IRS is not experts in medicine. They are coming up with the procedures. It just my understanding was that employees have a freedom to spend that money any medical licensed medical professional they want to choose. They can.
Nope, not if it's not for the purpose listed under IRC 213D in publication 502.
It is a mind-boggling even for the people who are in healthcare field. These regulations are overburdening everybody in that sense. But anyway, so the surgical center. The good news is in the whole overall thing you're saying that to me is that the surgical centers have a great options now. I think doctors should open a more surgical centers. They can get approvals much easier, even though it takes 3 years sometimes. But that is a way to go in the future. Do you agree with that one? That is the future of the healthcare delivery system.
There was a gentleman back in, I want to say 2008, 2009, an author by the name of Goldstein. And he said a phrase that echoed and resounded to me. He said, you have to match the model to the market. So if you just have a pipe dream to go and build an ASC, but the market doesn't need it and your business is not solving a problem, you may not succeed.
That is feasibility study, right? How many what the population versus that is a feasibility part of it. Not for the. I'm not talking about what. For example, I used to own an imaging center. Okay, then I charge $500 for MRI. They go, the same patient goes to the MRI center in the hospital, in the inpatient. They're $5,000 they're charging. That it doesn't make any sense, that discrepancy. So if I am if I'm politically savvy and if I'm aware of the system, I would go and prefer all the outpatient centers. No.
That was what some investors in Texas thought about building independent freestanding emergency rooms. And it didn't pan out.
Yeah, let us talk about independent emergency centers because you are there. I wanted to ask you. One of the thing is when you say urgent care, minor emergency care, they are giving a flat fee for the patient walks in. They say insurance company said that we give a flat fee. We're not going to pay you procedure, but if you do X-ray or ultrasound or if you do a procedure, they don't want to pay for that. They want to pay a bundled one fee to them. That is a big problem for a lot of these centers, and they lost money. Is that right? Is
Yep.
that, so
Yep.
it's not lucrative to open a minor emergency care walk-in clinics is not lucrative because of the insurance companies.
Well, and because many of the state laws require that an insurance company, an HMO, pay for emergency bona fide emergency care, that they must pay it without prior authorization or anything else. Now you have that No Surprises Act. And so the No Surprises Act actually conflicts with the state law of any port in a storm and TALA and some of the other rules about not requiring prior authorization for urgent or emergent care. But a lot of people misuse the emergency room because the primary care office is not open at a convenient time. If those cases are denied retrospectively, the center, the urgent care center, the freestanding ER gets no money and accumulates bad debt. Bad debt doesn't turn on the lights.
Before I leave, I want to ask you the countries like India, Thailand, and all these countries, medical tourism. What are their options now to they when they fell on in their face about the medical tourism promotions? I know one company opened in Silicon Valley. I told her that's not going to work out, but they were arrogant and then they failed. It's just a. So, what is their chances of successful in this area in the India and the Thailand or Japan, Korea, and all these countries?
You mean for a facilitator in the US or a facilitator in India?
India.
If they go looking for source market patients from Pakistan and some of the other local markets, they will
Yeah,
probably do well.
correct.
But if they are going to set up in Silicon Valley, a fool and his money is soon parted.
Yeah, that is going to be. It's a very complicated. It's just, more I listen, more I get confused about this whole thing. This is a this is a system we have. We need a simple system. I think, Maria, I've been in the medical field. I used to own an imaging center, and I did a lot of mobile diagnostics. It is really challenging every time. Still we don't have in rural Georgia, for example, we don't have access to a lot of people who don't know until 97th month they have a twins because nobody did a ultrasound on them. So we have a lot of these challenges at the head of this healthcare system. Really, quality of healthcare system, is the American paradox, right? You're spending more money and the less access to the less care. We have to solve. I think eventually the solved solutions may come from outside of the healthcare system, not from the healthcare itself, because they're adding more rules and regulations. It doesn't make any sense to me. So anyway, what is your final thoughts about the American healthcare system? What do you suggest to make it improve this healthcare system?
The American healthcare system is going to reward the innovators who can color within the regulatory lines and still build a product that the market needs. Every market is different. Utah is different from Georgia. It's different from New York. You have to open a business or create and launch and operate a business model that resonates with the target consumer, the target persona. If you don't know who that target persona is, what they want to buy, how they want to buy it, you're done.
Besides target persona, in my view, all the systems will fall into the system if there is a demand and supply is actually there. The laws can be changed. The people adopt the laws, and laws can be changed, because as long as the innovation. For example, I give you an example of Uber. Uber, a lot of times the cities have a lot of taxi. For example, New York, a taxi medallion, $1 million they were charging. All of
Mhm.
a sudden Uber came in and changed the entire ball game of the whole system. So eventually that kind of system will replace our overburdened healthcare system, regulatory healthcare system in this country. In my view, innovation is the key. I agree with you. Thank you so much for joining with us. It is an absolute honor and a lot of information for us. Thank you so much. How do they reach you if they want to reach you, and if they wanted to ask your consulting work? mariatodd.com, right?
MariaTodd.com, and I have a toll-free number that is 800-727-5800. 4160.
Can you repeat that again, please?
800-727-4160. That's been my number for more than 20 years.
So you do consulting, provide consulting services around the world, and right now you are doing the local, your state ambulatory surgical centers. You are working with them right now, right?
Tried to retire. It was the first time I ever failed at anything.
Okay. Yeah, so you wrote a lot of books, and I mean you have several books on the pipeline, right? You did 29 books. You said that mostly regulatory aspects, probably to educate the doctors and everybody else, right?
Yeah, all of my books are available on Amazon and then through the publisher. I'm an Informa author. So Informa out of Dubai takes care of all my publishing. I don't self-publish.
So just let's talk about Dubai a little bit. They're promoting a lot of nowadays. They're coming here. They're trying to promote. There is a place for central tourism. Is it anything that's going on in that area? Is Dubai is going to be the new center of healthcare excellence?
When I went to Dubai and looked at the Dubai healthcare city, I did not see evidence of that.
Okay, so so that's let us put that we get more confusion, more marketing, less. We have a really lost in this world. I think American healthcare system really need a true leader, a true innovator, and the leaders we need it. Thank you so much. Thank you for joining with us.
My pleasure.
Thank you all. Thank you all. Good night, guys, and good night, all of you.
Telling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.